Good afternoon, everybody. Welcome to Ask Dr. Geier Live, wherever you're watching. Hope you're making today your masterpiece. For those of you in the United States, I hope you're having a great start to your holiday weekend. We have a 3 or 4 day weekend, depending on if you take today off. So very excited and hope everybody stays safe out there. This is Lillian. It is good to see you. I hope you're having a good afternoon yourself. As always, I say this all the time. This is the one place that I answer orthopedic questions, injuries, surgeries, rehab, recovery, all of that kind of good stuff. I don't do it in response to emails. I don't do it in comments to videos. I don't do it just routinely throughout my other live shows or anywhere else, just because I've got other things I need to do, including a real job as an orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative expert, as well as a media medical expert for 2 TV stations here in Charleston. So this is your chance. Ask your questions. It can be a really short show if nobody has questions, or it can be really long. I will stay as long as there are questions. Please, 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 please understand that this is not medical advice. This information is just that. It's meant for educational and informational purposes only. I haven't seen you, examined you, looked at x-rays, looked at MRIs, surgery reports, arthroscopic pictures, any of that. This is really meant to help you understand what that injury is, what that surgery entails, what that rehab and recovery process entails, so that then you could go to your orthopedic surgeon, make the decision that is best for you. So feel free to ask. If there aren't many questions, I am going to hit the gym and have an early start to my 4th of July weekend. Trying to think of questions I've gotten recently. I got a lot of questions. Soom, I hope you're having a great day. I am having a wonderful day, thank you. Even though I have been up a long time. We had a real bad storm here in Charleston last night, and it knocked out my power. And I have these lights on, these Philips Hue lights, and they got turned on because I guess the power and internet went out. So that woke me up at 3 in the morning, which was tons of fun. Georgia, hello. Friday afternoon, Greece time. Yes, I am doing well, and I hope you are doing well as well. Greece is what, 6 hours ahead of Charleston? I think so. So if that's the case, it would be a little after 6 p.m. their time. All right, let me get back up to the top here. Lillian says, patella dislocation was scheduled for surgery today. Did you have surgery? That would be interesting. Not all patellar dislocations need surgery. I was involved in a workers' comp case not too long ago about patellar dislocations, and some of those need surgery, some don't. It really depends on if it's become a recurrent problem, and then that kneecap just keeps going out of place all the time, and there's underlying factors, anatomical factors that can play a role in that. But that surgery has evolved over the years, since from when I started, coming out of residency, coming out of fellowship, and now and then practicing to now, it's come a long way. They used to do bone transfers and try to realign the bone, and sometimes there are times that you need to do that. It's usually, not usually, almost never treated with the old school, what's called a lateral release. Now we a lot of times do what's called a medial patellofemoral ligament reconstruction. Really, really successful surgery. I had really good outcomes with it. So there's a lot to it. That is a long recovery. May not be ACL long, but it's typically 4 to 6 months to get back to sports and things like that. So Lillian, let me know if you didn't have surgery, why that was, or maybe they decided not to have surgery. I'm just curious more of the details. All right, Lydia, meniscus repair in August for a bucket handle tear. So we're now, what is that, almost a year. Stiffness and ache in my knee. Any tips to relieve this? Joint supplements or stretching help? So I obviously am as I've slowly sort of pivoted some of my practice. I still do traditional orthopedics and sports medicine, but I do anti-aging and regenerative medicine. Big fan of supplements, anti-inflammatory supplements like EGCGs, epigallocatechins that are found in green tea. The problem is a cup of green tea doesn't have that much EGCG, so an EGCG supplement, green tea supplement from a quality supplement provider might be beneficial. Same thing with curcumin, which is found in turmeric. The problem is turmeric doesn't have that much curcumin. Still helpful, but if you can get a curcumin supplement from a quality supplement manufacturer, that would be helpful as well. Omega-3 fatty acids, fish oils, essentially very anti-inflammatory. That can be helpful. As far as stretching, it really kind of depends on what the issue is. If you didn't get full range of motion back, that's going to be really tricky. Stretching might be helpful from a pain standpoint. It's hard 11 months out to expect that you're going to increase the amount of motion you get. Typically, my experience with why people still have knee soreness months and months and months after a meniscus surgery, after ACL surgery, something like that, is more related to not getting fully the strength back around their knee, especially the quads and hip flexors, VMO, also muscles at the hip, the abductors, external rotators, to take pressure off the internal structures in the knee. So working with a physical therapist to get that back, in my experience, can be fairly helpful. All right, let's see. Joint supplements, can you take it before surgery or even after? Foods that may cause inflammation. So there's two parts to that. As far as supplements, generally supplements are very, very safe. There's a few that interact, things like St. John wort, which was not anti-inflammatory. That is not for this purpose. But there are some supplements that can have interactions. Most of them, though, are very, very safe. I generally tell patients to stop supplements a week before any surgical procedure, just in case there's an interaction with the anesthesia or with bleeding. As far as diet and foods to avoid, I think that any food that you're potentially sensitive to or allergic to would be something I would avoid. So there are tests to determine that. There are food sensitivity tests and there are food allergy tests, but you could do an elimination diet. Generally, what I would say is try to do an anti-inflammatory diet, and what's an anti-inflammatory diet gets to more than I can really talk about here. But typically you're avoiding high glycemic foods. Typically the low glycemic index foods are also anti-inflammatory. So you're going to avoid processed foods, things that come in bags, boxes, cans, frozen food packaging. You're going to avoid white carbs as much as possible, especially carbs generally, but especially processed carbs. You're going to want whole foods that you have to cook, fruits, vegetables, nuts, legumes, quality meats, things like that. If you want to Google, maybe I'll do a video on an anti-inflammatory diet. I think that's really good for anybody, especially with musculoskeletal problems, which are largely caused or influenced by inflammation. But an anti-inflammatory diet, you could argue, would be good for lots and lots of people. The big ones, giving up sugar, giving up processed foods, processed carbs. All right. I'm not sure. I was so scared I'd be able to walk well again. Maybe that's why she didn't have the patella dislocation surgery. It is a recurrent problem. So again, very often that does become the type that physical therapy is not good enough to stabilize the kneecap, have the muscle strength hold the kneecap in place. So you end up doing a surgery. Good protocol for meniscal root repair. I would probably defer to your surgeon. Again, this is not medical advice, so what I say is not necessarily what you would do. I think the key would be probably a short period of limited weight bearing. Also, you would wonder about bending the knee past 90 degrees in the first 2 to 4 weeks. Any further bending might put extra stress on those stitches, potentially cause the stitches to break or the implants to break and not heal. Those would be kind of the main ones. Obviously, if you're limited weight bearing, you're not going to do any running or things like that. You could still do efforts to gain range of motion up to whatever point you decided, 90 degrees or whatever, that you couldn't do, and some efforts to get your quad strength back without irritating the meniscus is what I would say. Lydia says, my surgery will be later this year. I hope it goes well. Keep me informed. Come join us every Friday. Keep me informed of the progress. Adam in Nashville. So I am from Memphis, Tennessee. So my dad actually grew up in Nashville. So I love Nashville, and it has changed a lot since I lived in Memphis. Nashville is a great, great city. Hill-Sachs lesion, remplissage procedure. Success rate normally, still do therapy 4 years later, no problems. Didn't really understand the procedure. I'm assuming dirt bikes means dirt bike accident. So a Hill-Sachs lesion. Let me get my shoulder model here. This is not going to show very well because I can't dislocate the shoulder on this. But basically the ball pops out of the socket in a shoulder dislocation. Then what happens is, as that ball slides out, there's an impact of the back of the ball, the humeral head, with the socket, and it leaves either a bruise or, in a Hill-Sachs lesion, an actual divot. If you can imagine a golf ball landing on a putting green on a golf course and it leaves a divot, it's the same idea. If that Hill-Sachs lesion is big enough, you actually have to fill in the defect, either with bone graft or remplissage, which is where they transfer one of the rotator cuff tendons in the back of the shoulder to that area to add stability. The success rate is usually pretty good. Sometimes there's a loss of motion with that, but as far as recurrent instability, that is usually pretty good. Without knowing more about the procedure, that's what I would say there. As far as options other than surgery for patella dislocations, initially, like I said, a whole lot of the time you can get people better with a patellar dislocation without surgery. You're talking about sometimes short-term use of a patellar stabilization brace, sometimes physical therapy to restore the strength of the muscles around the knee and the hip to basically provide dynamic stability for the patella. But in some people, that isn't enough to get it better. Jerry, scheduled for ankle debridement. Notice the term subtalar arthroscopy. They're basically just going to stick the scope in. I would assume ankle debridement, they're doing it in what's called the tibio-talar joint between the... I should have prepared for this. Hang on. Now we'll switch to the ankle model. The tibio-talar joint between the tibia and the talus, that's what most people think of as the ankle joint. The subtalar joint is the joint below the talus, so between the talus and calcaneus. So maybe they were thinking they're thinking, I don't know that they're going looking in that. That just may be a, hey, what if we don't find anything? Do we need to look in there? But maybe they're worried there's some scar tissue in sort of the joint below that. Lydia, you are, clicked on the wrong one. You are very welcome. I hope that was helpful. Injured the MCL last year, May 31st. So we're over a year out. Intensive therapy since then. Soccer trier come up. Do you think? Yeah, I mean, I can't, again, this is not medical advice because I haven't seen you and examined you, but assuming that the MCL, the medial collateral ligament of the knee, has completely healed, assuming you have full motion back, assuming you have full strength back, and you can do sport-specific activities, in this case, soccer and cutting back and forth, I would see no reason this far out that you wouldn't need surgery. And no, most MCLs do not typically need surgery. Priscilla, I assume that's degenerative disc disease. That's kind of a tricky thing. Typically, you want to treat that non-surgically unless you have a herniated disc putting significant pressure on one of the nerve roots that's causing a radiating pain down one of the arm, weakness in the hand, numbness, tingling, things like that. And non-surgical treatments aren't working. But yeah, you think of things like physical therapy, maybe anti-inflammatory medications, sometimes nerve root injections done under fluoroscopy, but they can inject cortisone into the area of the nerve root to protect it. Those types of things typically helpful. Sometimes I have heard talk of penisin polysulfate, which I've done a video on as a non-surgical treatment for osteoarthritis. I have heard people say that it might be helpful for degenerative disc disease of the neck or the back. I have not seen studies on that. The Australian studies looking at penisin polysulfate for osteoarthritis were looking mainly at the lower body, the hip or the knee. But having said that, that potentially is an option. But you typically do that. It's typically not a surgical problem unless you get an actual herniated disc. So grade 2, grade 3 MCL, even those can heal without surgery. Sometimes grade 3s need surgery, but again, a year out, if that ligament healed, and the surgeon can tell that even without an MRI, you can do a physical exam and see how much the knee sort of opens up with side-to-side stress, and you can kind of figure that out. How does Donald, good to see you. I know you were here yesterday for Better Than Ever Live. cadaver ACL work in my knee. What's a mechanical block? So two different issues. That the cadaver is just a type of graft. So when you do an ACL surgery, at least the typical reconstruction, you make a new ACL. You can use tissue from in your knee, part of the quad tendon, part of the patella tendon, one of the hamstring tendons, or you can use tissue from a donor, and that's usually either somebody that's died, basically, and they harvest the organs, usually patella tendon, sometimes hamstring tendon, I guess, or the Achilles tendon. It's thought that the cadaver has less pain in the first few weeks after surgery because you're not harvesting tissue from your knee, but the failure rates have been significantly higher, sometimes as high as, I've seen numbers as high as 4 times higher failure rates. Typically, we don't do them on young, active people, and you could debate young, I would say under 40, maybe under 50. I don't like cadaver grafts much at all. Even in revisions, sometimes I'll try to avoid them, but sometimes that becomes a necessary evil. But it becomes largely down to surgeon preference and patient preference. As far as mechanical block, that is usually scar tissue, maybe a torn meniscus that's blocking range of motion to the knee is typically what most people mean by that. All right, Priscilla says L5. I would think that'd be L5S1, but maybe you have some different anatomy. But yeah, so that would cause potentially herniated disc, putting pressure on the nerve root going down your leg into your foot and ankle, numbness, tingling, things like that. Again, those are typically the treatments before it gets to surgery. Jerry says, want to make sure a bone spur close to a ligament. I don't want work on due to the chance of damaging the ligament. Yeah, without knowing more, I'm not really sure I can tell you too much about that. Arthroscopy is usually a fairly safe procedure, and one of the nice things when you scope the ankle is you can see those lateral ankle ligaments from inside, so you can try to avoid them, but I do get that concern. All right, that is all I see. I hope you have a fantastic rest of your day and rest of your weekend. If you want to see me formally as a patient, the link to my website's below. Fill out the contact form and we can figure out how to get you to the beautiful Charleston, South Carolina. Not beautiful this weekend, though. It's looking like we're getting 3 or 4 straight days of rain. Oh well, no beach time for me, or maybe little beach time, but I hope you have a fantastic rest of your day. I will see you back here next Friday for Ask Dr. Geier Live, and next Thursday afternoon, 5 p.m. Eastern Time for Better Than Ever Live. Hope you have a fantastic rest of your day. Take care.